Good morning, good afternoon, and good evening, everyone. Welcome to the next session on new radionuclide therapies and guidelines. I'm Ziting Lee from Melbourne, Australia. So without further ado, I will introduce you our three speakers for this session. The first is Dr. Hsiang Kao from my own home state. And he will be talking on concepts in predictive dosimetry for radioembolisation beyond the liver. Dr. Kao is a nuclear medicine physician with an interest in predictive dosimetry, who's qualified in Singapore and Australia, working in multiple tertiary hospitals in both countries, and he's currently at the Royal Melbourne Hospital here. He has numerous publications on predictive dosimetry in selective internal radiation therapy and is advocating for nuclear medicine specialists to shift away from traditional empirical methods and to embrace scientifically sound methods of radionuclide predictive dosimetry. Our next speaker is Professor Mike Sathekge from South Africa, who has already spoken in a previous session but this time he'll be speaking on rhenium-188 therapy for BCCs and SCCs. He is a professor and head of nuclear medicine in University of Pretoria and Steve Biko Academic Hospital, president of the Colleges of Medicine in South Africa, and has held executive positions at numerous international organizations, including ICRT and World Federation of Nuclear Medicine and Biology. And he's also been a recipient of several distinguished awards for research and service in this field, including being an internationally acclaimed researcher by the National Research Foundation, and is a member of the Academy of Science of South Africa as well. His publications and presentation record has earned him editorial roles in peer-reviewed journals, most recently as the co-editor-in-chief of the Seminars of Nuclear Medicine. And our final speaker for this session will be Professor John Buscombe from the United Kingdom, who will be speaking on the updated guidelines on bone palliation therapy. Professor Buscombe is a visiting professor at the University of Pretoria at the moment and the president of the British Nuclear Medicine Society. He's previously worked in London and Cambridge in the United Kingdom and has had a long-standing interest in radionuclide therapy, having published over 70 papers on this topic. He's also the past editor-in-chief of the World Journal of Nuclear Medicine. So with that, I hope you would enjoy this session, and we will touch base with you after that. Thank you.
Hello, everyone. I am Dr. Kao, and I'm a nuclear medicine physician at the Royal Melbourne Hospital. I would like to thank the organizers for inviting me to share with everyone some concepts in predictive dosimetry for radioembolisation beyond the liver. First of all, this presentation is meant for general education. There will be some concepts that will be quite advanced and quite difficult to understand. Please do not implement any of these concepts without expert advice. The content of this presentation comes from a dosimetric paper that has been published for several years in cardiovascular and interventional radiology. And if you would like further details, you can refer back to this original dosimetric paper. First of all, we need to clarify a few concepts. So radioembolisation is a form of arterially directed brachytherapy. So it uses interventional techniques to inject radioactive microspheres. The radioactive microspheres are permanent implants in the arterial territory that you want to treat. And because they are permanent implants, it is a form of brachytherapy. As a form of brachytherapy, radioembolisation dose response is predictable. In other words, if you inject a certain amount of radiation absorbed dose, for example, 100 gray to a certain tissue, you can expect a certain dose response. And therefore, it is only logical for radioembolization to be expanded to other parts of the body other than the liver. Radioembolization beyond the liver is not new and has been done many decades ago, as early as the 1960s, as described by Blanchard. So this is a summary of the studies that I know about that have used radioembolization to treat tissue in different parts of the body, such as in the brain, the tongue, the lung, the stomach, kidneys, spleen, and adrenal glands. So you can see there is a small amount of clinical experience, and over the next few years, the number of reports for radioembolization beyond the liver is going to increase. What we need to plan this kind of treatment well is a combination of three things. First of all, we need the right people. Radioembolization beyond the liver is usually used for very complex and difficult to treat tumors, and in that setting is usually discussed in the setting of a multidisciplinary team. And within the multidisciplinary team, the most important is for close collaboration between interventional radiology and nuclear medicine. For the nuclear medicine team, we need knowledge in predictive dosimetry, and the minimum standard is MERD, medical internal radiation dose. If your institution has voxel dosimetry, that would be the best. And in terms of equipment, for interventional radiology, the minimum standard would be some form of catheter-directed CT, such as the cone beam CT, or even better, if you have a hybrid angio-CT system within the angiography suite. For nuclear medicine, the minimum standard would be SPECT-CT. Before we delve more into the concepts behind radioembolization beyond the liver, there is another concept that we should clarify before we proceed. And that concept is the traditional liver to lung shunt calculation. So, contrary to popular belief, the formula for liver to lung shunt calculation that all of us use is not always true. And here at the bottom is an example of the traditional formula, which I've taken from the Sathekge training manual. And we all know this equation because almost everybody uses this to calculate the lung shunt fraction. But what is wrong with this formula? The problem is here, and the entity that I'm highlighting is the entity that describes the activity in the non-tumorous tissue. So the problem here is that the standard liver to lung shunt formula assumes that the non-tumorous tissue will always contribute to lung shunting. In other words, it assumes that arteriovenous malformations will always exist in the non-tumorous tissue. Such a broad assumption may sometimes be untrue, depending on individual circumstances. And the consequence of this broad assumption is that if we use the traditional liver to lung shunt formula, we will systematically underestimate the true lung shunt fraction. And that is because this entity, which is the activity in the non-tumorous tissue, always exists in the denominator. And therefore, even if this entity does not contribute to the lung shunt activity, it will always be there to artificially enlarge the denominator, and therefore you will systematically underestimate the true lung shunt fraction. So how do we overcome this problem? The problem is overcome on a case-by-case basis. The nuclear medicine physician needs to consider for every individual case whether the broad assumptions of the standard formula is applicable to each patient. Otherwise, the nuclear medicine physician can choose to use the alternative formula, which is the tumor to lung shunt fraction, which has been previously described in another dosimetric paper. So now that we have clarified the concept of the tumor to lung shunt fraction, we can now begin to discuss the dosimetric theory for radioembolization beyond the liver. Hypothetically, radioembolization beyond the liver may be considered for any angiographically accessible tissue that has been simulated to be safe and effective. It is important to emphasize that all of these keywords, which is angiographically accessible, simulated, safe, and effective, they are all essential for radioembolization beyond the liver to work effectively to treat a patient. So here we have a hypothetical scenario where there is an area of tissue anywhere in the body, and this tissue contains a certain tumor that you want to treat. So the key to safe and successful radioembolization beyond the liver is the simulation. And in this case, what we should do is always to use a form of catheter-directed CT to delineate the target arterial territory. And the important reason why we need to delineate the target arterial territory is because we need to know what is the mass of the tissue that we want to treat, because the mass will relate to the radiation absorbed dose, which in turn translates to the radiation activity of the microspheres that you want to inject. So in this case, most institutions would have cone beam CT in their angiography suite. The alternative, which is a better modality, is angio-CT. And for institutions that are not lucky enough to have a hybrid angio-CT in their angiography suite, the alternative is to transport your patient from the angiography table to and fro a CT scanner with the catheter in place, and that would give you very high quality images of the target arterial territory. But this to and fro transport between the angiography table and the CT scanner does take a bit of time and forward planning. In terms of the radiomicrosphere simulation, the nuclear medicine team should choose a suitable inert surrogate. And for many decades, the surrogate has been technetium-99 labeled macroaggregated albumin, or MAA. And we would image the distribution of the MAA using SPECT-CT. So this has worked very well for many years, but on the horizon is the possibility of radio labeling MAA with positron emitting isotopes such as fluorine-18 or something else, and to use the better resolution of a PET-CT camera. So if your institution has the ability to use PET-CT to simulate a treatment, that would be ideal. So in this simple dosimetric scenario, at the point of injection, the simplest scenario is that all of the injected radiomicrospheres all travel into the tumor and gets permanently implanted into the tumor, and there is zero shunting of microspheres into the lung or to the non-tumorous tissue. So this represents the easiest dosimetric scenario. And the way to calculate the desired activity is using the very simple MERT formula, which is given here. So let's consider a slightly different scenario where we have a tissue that contains multiple ill-defined tumors that are difficult to measure and difficult to individually define volumes of interest. Again, we need catheter-directed CT to delineate the target arterial territory so that we know the mass of the tissue that we want to treat. And in most cases, we would expect some shunting of the injected particles into the lung. So in most cases, you would expect the patient to have some tumor to lung shunting. So in this case, what we should do, because it's difficult to individually measure each ill-defined tumor, we can dosimetrically plan a single mean absorbed dose across the entire target territory. In other words, this entity activity into the tumor actually represents the average activity across the entire target territory. And the way to work out the overall activity to inject is provided here based on the MERT formula. So let's consider a third scenario. So again, we have a tissue that contains a certain tumor that we want to treat. Again, we need to simulate the target arterial territory with catheter-directed CT. And here we have a situation where the injected microspheres will go into the tumor. Some of it will also go into the non-tumorous tissue. And from the tumor, some microspheres will be shunted into the lung. So this scenario is quite familiar. It's quite familiar because we sometimes see this situation in cases of conventional liver radioembolisation, where there are 3 dosimetric compartments, which is the tumor, the non-tumorous tissue, and the lung. But in this case, the difference in the calculation in this case as compared to the standard partition model is that we use the tumor to lung shunt fraction instead of the liver to lung shunt fraction. And the MERT formula to work out the total activity to inject is provided here. Remember, an understanding of predictive radionuclide internal dosimetry will liberate you from the traditional empirical paradigm and expand your horizon with limitless potential. Thank you for listening.
Good evening, good morning, people around the world and friends of Warmth. I'm Mike Sathekge, the President-elect of Warmth, and I'm glad for the organizers of this ICRT and the entire team, from the presidents to everyone that have organized this. That it's an amazing thing that we can do this wonderful thing during this COVID time. Today I will be speaking about rhenium skin therapy on basal cell cancer and squamous cell cancers. Essentially speaking, just to give a brief background based on the South African experience, because we do have a lot of sun just like other people, it's that really basal skin cancer and squamous cell skin cancers are really growing in numbers, and it is concerning that especially the males that are really having a lot of it of BCC and SCC. These cancers, of course, not so lethal like the prostate cancers, breast cancers, but they are something to worry about in terms of the cosmetics. And as you can see, really indeed, based on all the groups, that really indeed the wide cohort is really having a problem with this. And the manner in which it presents, it's usually common in the head and neck, lower limb, trunk, and upper limbs. But of course, the head and neck is where we are having cosmetic issues. How we treat it is essentially like how we treat all the other cancers in nuclear medicine, using either a beta or an alpha emitter. But today we are going to speak about beta emitter. Rhenium-188 is a beta emitter, which is essentially an important thing, and I'll speak about the kinetics of it, of how it can actually destroy the SCC or BCC and yet not lead us into carcinogenesis, or the cells won't survive. As you can see in this diagram, we are aiming to actually reduce the crossfire by giving exactly the required amount. So how does this skin therapy begin? Actually began with Marie Curie, when in 1898 she spoke and used the radium-226, and then of course that indeed was transferred to a treatment of skin cancer as early as then. As you can see in this archaic journal, clearly that was then done, which is something that we had forgotten already. Radium already was used for skin cancer, and successfully so. But that practice didn't take far, and it died off, probably because of how to handle radium at that stage and the dangers of radium, but it is resurfacing. So dermatological brachytherapy has also been used using radium and means of treating it with other ways, which I will not go with irradium, which I will not delve into, because that's really a bit difficult to really navigate in a short period of time. But as we know, radium-188 in itself, the decay scheme of it, it's something that is utilized by many people, especially the Warmth colleagues and Warmth community. They are utilizing this radium-188 for various things, for bone palliation, for liver metastasis using laperidol, bound to it. So I will not go again into this kinetics or into the decay schema of radium, but basically you can have a generator and then you can have it on your side. But in this particular instance, it's going to be slightly different, and we'll see how. It has got the half-life of 17 hours, and that's important to know that. And then of course, the emission that it gives us, it's a beta 1, 2,1 MeV, which is good, and it has got a short range, which is just enough to attack the skin cancers. It has been used in various situations, as one has said, bone palliation, hepatic carcinomas, even in the cardiac situation, radiosynovectomy, and of course, it can be lately labeled with FAPI. That is going to be interesting to see how we can attack various cancers. Of course, we are going to speak about the skin therapy for today. Just an example of how, when you do actually coronary restenosis to prevent it, you actually can apply radium, and you can see that it will prevent a restenosis. And again, if you can use it, utilize it in the vessels internally, in the coronary arteries, it means you can actually utilize it very well for skin therapies. And that is why I'm showing deliberately this one, as it is again an old work, just to show that it is actually a safe technique. If you can use it internally, then you can use it safely in the skin. So how does it work? You can see that radium in itself, when it is applied in the skin, it will not go beyond the epidermis. It will be confined only to the epidermis and not the dermis, which is a good thing because that's where BCC or SCC is going to be found. So therefore, you're not going to damage the dermis, which is an important aspect. Of course, and of course, if it penetrates 3 millimeters, that's important. You are normally targeting to have 50 grays around the skin at that stage. And of course, you protect yourself in that particular instance. And then I'll show you such. This is how you do the wear protection of how you protect your ears as the patient. If you are applying the therapy around the eye, the eyes or the nose, the face, you will protect the mouth, will protect the nose, will protect the ears and the eyes. And then, of course, this shows what is the radiation when it is protected and when it is not protected. And that's really playing with time. But just to show that there are precautionary measures that we normally take. And us as personnel, when we apply it, of course, we wear the lead shielding and we wear the glasses as well to make sure that we are not indeed exposing ourselves. This is the device in itself. This is the applicator. That is where you do the dose measurement, the dose calibrator, and that's where you discard the waste part of it. This applicator is an easy one to use, and it is using this scalpel. You essentially have rhenium applied in the scalpel, and you attach it there, seal it, and you apply it into the patient. And as you can see, this is again showing you how the cancers are really there. Melanoma tend to go to the dermis, but we are dealing about SCC and BCC, which are confined here. And as we have said, it travels 3 millimeters and it's confined there. Just to show you again that in a physics schema that clearly it is safe, you are easily going to impart your 50 grays without really imparting and causing damage to the normal skin. So now there are 5 stages of applying this therapy. How do we do it? It's important that you remove the scalp first. You remove the tissue so that when you apply it, the penetration is going to be uniform in the skin. You don't want it to be rough around the skin. So therefore, you'll wash it out and make sure that the penetration is better. You've got homogeneous distribution. Therefore, you'll get a definition of the area just out of the border of the lesion itself. This, because it's a multidisciplinary effort, either a plastic surgeon or a dermatologist will help you as a nuclear physician to draw around, and so that you don't do the mistakes of missing what is the diameter around it, so that it's clear. As you can see, it must be 2 to 3 millimeters beyond the visible edge, and the dermatologist does that very well. And then this is just to show that you must then protect the patient depending where you are applying the rhenium, and all the protection will be effective to make sure that there is unnecessary radiation. Now in itself, then you don't even touch the skin of the patient. You apply foil around the skin, the place where you are going to apply it. And then of course, the rhenium will be coming in the form of a cream, as you can see, a thickened rhenium, not in a liquid format, because so that it doesn't actually spoil and go around and contaminate the patient. And as you can see, then when you measure it, you always then measure and apply to see and measure the activity that is remaining, so that you can then do the calculation to know how much of it you have applied, and then therefore how long the patient should stay for you to get the required results. So it's as easy as that. This 5 stages tells you what is happening, and of course you remove the foil when the time comes, and you just discard it. Just shows you in a schematic format that was the lesion, applying the foil, and then drawing the region of interest, and then applying. As you can see there, one is trying to demonstrate that, and then after a while you remove this foil. You haven't touched the patient directly, and these are the results that happen from this to that. Of course, demonstrating that this is a single session therapy. It is painless, non-invasive, and the results are very cosmetically favorable. So this is the thing to go showing here with the team in my department. Of course, as one has said, you can apply to various skin lesions, squamous cell, bone carcinomas, and probably melanoma as well, not discussed here. What type of lesions? They can be plain lesion, they can be nodular, they can be keratin, eroded, ulcerated, giant cell. As you can see in the schema here below, all these lesions, so long as you have actually cleared them, you can actually apply therapy to all of them, and that is the nice thing about it. In our experience, of course, as you can see clearly here, we really actually show what is seen elsewhere, that indeed the nose for some reason is the one that will have the lesions that are really mostly there. And then of course most of the time people get almost above 90 remission in one therapy. Occasionally you may have to repeat the lesion, especially if the therapy was bigger. You may have to do that. This is the team from Italy, as they were working with a team called Oncobita, that shows that this is the way it is. In India, they haven't used this applicator that I'm using about. They've used something that you have a plastic and put the liquid format of rhenium inside of it and apply the lesions. Of course, it works. It is much cheaper, but unfortunately, in terms of measuring how much you have given and potential contamination can be a bit of a problem. And they tend to actually repeat the therapy, whilst with the method that I have described with the Oncobita applicator, you actually end up doing it once and it's effective and it's safe and there isn't potential for contamination. As you can see, the applicator been there, and then that is what we have. So far, we have treated several lesions. There are lots of patients that are really qualifying for this, but the financial toxicity stops us from treating a lot of patients. We hope that as we present in a setup such as Warmth, that this thing can become available to many colleagues in South Africa and elsewhere across the world, and we can actually have this being funded as well. Showing some of the examples, as you can see in the forehead, in 2 weeks, just to emphasize, it gets to be a bit worse. You have a scab that will end up removing. It falls on its own. The patient mustn't use lotions on the face or anything after applying the lesion. And then these are the results. And you can see that really there is hardly any recurrences that will be there. Another lesion, as you can see in the neck, as I said, the head and neck are commoner one. Small, big lesions that you can see, again, in 2 weeks getting bigger, and then later on it's cleared up. Can see again in the forearm, big lesion, escape in 2 weeks, and this is the patient. And of course, should have taken a better picture of him again. Now, after several months, the lesion in this 84-year-old male with SCC, it's still healed. This is another patient of ours in the nose. As you can see, the two lesions again getting worse, and ultimately it is better. You can see again, this is there, and then it's getting worse, and then of course these are the results that we could get. This is an interesting one. As you can see, a BCC, very, very obvious in the face, really disturbing. The patient has had several therapies that are really, keeps on having recurrence of the lesion. It keeps coming back over and over again, and that is disturbing for the patient. And you can see that in 2 weeks, this was the situation, and look at the results. It's gone forever, and he's a happy man. So we in South Africa tend to also have patients, black patients tend to have keloids. These keloids tend to recur after radiation and after surgery, which can be a problem. So I'm demonstrating it, a big circle. So how do we handle and break this circle? So this can also be a situation of such. You can see this is a big thing. There was no surgery applied after several that were there. And then we had this lesion from this patient, we have applied it, and then in the interim it was this, and this is that was 3 months. So there is a big potential for keloids as well, which is something that is good, because that is a big market that is waiting there. Again, showing you there that we are trying to break the cycle. And then this is of course, there is discoloration. Probably with time, the patient's skin color will probably come back, but this is there, and really we are again impressed with these results. You can see it's a big linear lesion here again, going there, and ultimately is there. In this patient, we have very little bit of a side effect, just a tiny application of the rhenium there. Ended up having a discoloration. It didn't have, as you can see before, it didn't have any lesion there in that particular instance. So one should be cautious when applying that. No normal skin should actually be contaminated or applied with this. So to conclude, colleagues, I'm saying that this is a very wonderful therapy. It's a non-invasive, painless, single-session therapy. Really, it has got over 95 remission in many hands, and really simple to use. It's an alternative therapy. Not all the BCCs and SCCs will be treated, as it is a multidisciplinary. Those lesions that cannot be treated by the plastic surgeons, they will therefore come to us, or those that are recurring after therapies. There are promising results in keloid. Watch the space in terms of those results. And then, of course, there are positions wherein it's difficult to have surgery or radiotherapy. Will be there, including penis, for instance. There's results from Italy showing this applied in genital places such as the penis. And then, of course, as one has said, it is a multidisciplinary team, and we are looking forward to having formalized trial that can make this be adopted as a formalized therapy. Thank you.
Hello, my name is John Buscombe. Good day to you. I don't know where you are. It's either good morning, good afternoon, good evening, or good night. I'm a nuclear medicine physician from the United Kingdom with 30 years experience in radionuclide therapy and have been involved with warmth from the very beginning. I also have an academic post in South Africa, and today we're going to discuss the updated guidelines of bone pain palliation therapy. So we'll start straight off. So the first thing I need to do is give my disclosures. Not very exciting because I really don't have any. But I think I do need to say that some of the products mentioned may not have marketing authorization in every country. So obviously you need to check that locally. Well, what we're going to do? Well, we're going to look at a little bit about the natural history of prostate cancer. We're going to talk about some of the beta-emitting products for bone pain palliation, some of the guidelines that have been produced for that. And then we'll talk about radium-223 for metastatic prostate cancer and the radium-223 guidelines, which are more modern. So it all starts with the bone scintigram, and I'm sure we've seen bone scintigrams looking like this, where we have the multiple focal uptake of bone metastasis, and we can see here that they're fairly widely distributed. And this is the kind of patient that we will be treating, particularly if they have bone pain. Primarily prostate cancer, but also there are some other cancers that we can treat, including metastatic breast cancer, but most of the practice has been in prostate. So let's talk a little bit about prostate cancer, because this is one where we're really involved in nuclear medicine, both in imaging and in therapy. So the patients have an initial diagnosis and treatment, and then they go on to having ADT, which is basically a chemical castration. And they may continue on that for many years. And then unfortunately, at some point, their tumor may escape that and they become castrate-resistant prostate cancer. And shortly after that, they tend to get metastasis, and they may get some serious adverse events, particularly bone marrow failure from their metastasis, and that leads to death. Now, for some people, unfortunately, this may be a very short process. It may be in a matter of months. But for the majority of our patients, we can probably count this in years. In terms of the incidence of bone metastasis, there have been several major studies that have been published. And generally, it's between low 80s to high 90% of patients present primarily with bone metastasis. Now, since we've had PSMA imaging, we realized that many of these also have soft tissue metastasis, which we couldn't find with other techniques. But if we go back historically, then using bone scintigraphy in CT, we find there's a significant proportion of patients that only have or appear to only have bone metastasis. So how was the radionuclide therapy for bone pain evolved? Well, it all started with very early work with phosphorus-32. And there was a lot of work done in Eastern Europe using this technique because it's a fairly low-cost radioisotope. But one of the real problems we have with it is that it can cause quite significant toxicity to bone marrow, which has limited its use. So the first truly sort of designed bone-seeking agent was strontium-89. Now, strontium is a type 2 element along with calcium, and so it would be a logical choice to use strontium instead of calcium. The distribution in the body is very similar. It had been noted to have some increased toxicity in patients who had widespread bone metastasis, but if we compare the two isotopes, you can see that strontium has a very long half-life and a fairly soft beta. Phosphorus has a shorter half-life and a slightly more energetic beta. The difference is that we think that phosphorus is contained in the bone around the bone metastasis in the ratio about 2:1 compared to normal bone. But along with other bone-seeking agents, strontium seems to have a ratio about 10:1, so you can give a little bit more. And normally there's a fixed activity of 150 megabecquerels of strontium given. So went under the name Metastron. It's well tolerated, and up to 80% of patients will notice that they have a drop in platelets. It normally recovers to normal after a couple of months. Grade 3 and grade 4 toxicity is rare. About 70% of patients record some bone pain relief, and about 22% from a Canadian study had complete bone relief. And you can repeat the treatment around about 6-month intervals. But this is a patient who we sometimes see, 64, he's got pain in many sites. He's got a fairly borderline hemoglobin and lowish platelets. And we do a bone scintigraphy, and he has what we call a super scan. Now, this patient may do very badly if we give them strontium. They may go into quite significant bone marrow failure. So what was the next stage? Well, the next stage was to look at these mixed beta-gamma emitters. And the one that was used most commonly was samarium-153 attached to EDTMP or lexidronate. And this has a much shorter half-life and a much softer beta. Also has a gamma emission, so we can take scintigraphy as well. Rhenium-186 HEDP was also developed. And this, again, has a slightly longer half-life, but again, fairly soft beta energy and produces slightly better images. The odd one out was TIN-177M that was developed in the United States. It has a fairly long half-life, but it doesn't have a beta as such, but an electron capture electron which is emitted, which is much softer, but also has a gamma emission. This didn't really go very far, but has been changed into a product which is used in the veterinary world quite widely and is used to treat arthritis in dogs and horses. Most experiences with samarium-153, and if you want to know what EDTMP is, it's ethyl ester methylene phosphatase. Well, so what? It has, as we said, that these have shorter half-lives than the pure beta emitters. It's not dependent on calcium deposition because it's a bisphosphonate, so it very much follows what you see with a technetium MDP bone scan. And the tumor to background ratio is around about 10:1 or even higher. And what we see is a very rapid upset into the bones and then fairly quick clearance over 24 hours of anything that doesn't actually stick with the actual bones. So this is the first product to go through what we would describe as a formal phase 3 trial, and this was done in both the US and Europe by the company that then was sponsoring the product. And what we could see that there is two graphs. The first graph is people identifying their pain, and they put it on a chart between 1 and 10 and how much it changes over time. And the orange line is the placebo, showing there's a bit of a placebo effect. People do wish they feel better even if they don't have a response. But the blue line you see is the response with the samarium EDTMP. And many of the patients, the pain just went away completely. And that pain relief starts at around about 2 weeks. And if you look very carefully, the dosing rate is 1 millicurie or 37 megabecquerels per kilogram. Now, what is interesting, of course, is the patients were seen weekly in the clinic and they would give their pain diaries over. And you can see why the placebo group managed in the second graph to get some pain relief, because it's the amount of opiates they were taking. And because they still had pain, they were asked to take more opiates, and that's what got rid of their pain. But in the group treated with the samarium, they could actually reduce their opiates as well as have pain relief. There was effect on things like platelets and white cell count, but again, this was fairly temporary. And certainly by 10 to 12 weeks, everything had returned back to normal. And therefore, you could retreat at around about 12 weeks. The limitations of the trials, obviously the primary have been pain relief. There was thought there could be an advantage in combining the treatment with maybe some other agents such as a taxane or some of the new chemical castration agents like abiraterone. But it never really got going, unfortunately. Other people thought it might be worth adding it to a bisphosphonate. But again, there was no phase 3 trials, which is a pity, because I think it would have actually come out quite well if we'd been able to give repeat dosing and some other treatment at the same time. As always, the concern is toxicity to the bone marrow, but obviously the bone metastases themselves are toxic to the bone marrow. So it's always a bit of a balance between the two. And one of the concerns was if you treated patients with these radionuclide treatments, then they couldn't then go ahead to have other treatments such as chemotherapy. And this could result in greater toxicity. Now, there was no real evidence for this, but it was a concern. If you want to look at the most recent guidelines, you need to go back to 2008 to the ENM guidelines. Now, there are other guidelines around, but this is probably one of the most comprehensive set of guidelines. And this really looks at strontium, samarium, and rhenium-186. It doesn't really include P32, which had fallen out of favor by that time. But they are good guidelines, and I think they're still relevant today. So what about radium? So radium is the new or relatively new agent. It's been with us now for 5 or 6 years. Again, it's a group 2 element, so it sits in the periodic table. If you look at the blue column, it starts off with beryllium, and then halfway down is calcium. Below that is strontium, and right at the bottom is radium. And so like strontium, it's taken up into bone at the sites where it's trying to heal itself. Now, this is a little cartoon. It's trying to demonstrate that one of the reasons is that the alphas may have an advantage. With a beta particle, such as even the soft betas that come from samarium-153, you will get a reasonable irradiation for up to about 1,000 cell diameters. And that sounds good because you can kill more tumor, but also you might irradiate, for example, more bone marrow. With the alpha particles, you only get up to around about 10 centimeters of penetration, plus you get much higher levels of radioactivity decay and energy transfer. So you're more likely to get tumor cell death by double-strand DNA breaks, but you're less likely to penetrate so much into normal tissue, such as normal bone marrow. The other advantage of radium, unlike the alpha the beta emitters or the mixed beta gamma emitters, is that alpha emitters have complex decay mechanisms. So radium itself goes down a set of decays so that it gets down to stable lead 207. And those decays over 11 days, most of the ones outside of radium are fairly short half-life. And this gives you 4 alphas and 2 betas, though 95% of the energy is emitted as alpha particles. So it really gives you what President Truman in the United States once called in 1950, more bangs for your buck. This went through a phase 3 trial known as the Alsimca trial, where radium was given to 2/3 of patients at a rate of 50 kilobecquerels per kilogram. And this was done with 6 injections at 4-week interval, plus best supportive care. And these was randomized against just patients having saline. Now, neither the doctor or the patient knew what was in the syringe, so we weren't allowed to scan the patient afterwards. Only the radiopharmacist who prepared the syringe knew what was in the syringe. And that was determined by a randomization process. Patients were either treated before taxane or after taxane. However, it went about half the patients had taxane chemotherapy before. So when we look at the overall results, now here, this is something slightly different. Here we're looking at survival, not pain relief. And when we look at survival, there was an increase in survival of around about 3.5 months compared to placebo. But remember, all these patients are really much at the end of their journey with their cancer. So it may not seem very much, but in fact, it is probably a significant change compared to what was available beforehand, because these patients have basically been offered every other anti-cancer treatment. In terms of skeletal events such as increase in pain, then it looked like you could get reasonable pain relief up to around about 16 months on average. Now, these are on average. Some of our patients have done much better than that. So it does also treat pain. So the idea is that you can live longer and live better, which is what is sometimes called a win-win. In terms of adverse events, if you can see, it's quite a busy slide, but I'm sure you can have a chance to look at this at your own time. But if you look at the column where it says all grades, the first column is radium 223, and only 5% of patients with radium ended up having significant bone pain compared to 62% with placebo. So it clearly is very good at pain relief. And to be honest, it's probably better than the beta emitters. In terms of its toxicity to the bone marrow, it was no worse than having saline, partly because you may get a bit of toxicity from the radium, but you have to balance that against the toxicity of the tumor that's untreated. The only symptoms that were more common in the radium group were gastrointestinal, and that's partly because it's excreted through the bowel, and particularly diarrhea was more common, but that's easily treated by loperamide. And if we look at the final column at the end, which is grade 3 and 4 toxicities, so these where patients have really serious toxicities, you'll notice it's not really worrisome. Only 2% of patients had a diarrhea that bothered them. And in fact, strange enough, so did the placebo group. So this may just represent underlying conditions. So who do we treat and when do we treat? So this is where guidelines come in, because guidelines help us decide where we should fit the radium in with other treatments. So in 2013, actually before it was actually licensed, the UK National Institute for Healthcare and Clinical Excellence, who are the sort of our guru for what to do, produced guidance on the use of radium-223 for treating hormone-relapsed prostate cancer with bone metastasis. And using the results from the Alsimpica trial, they worked out we should treat patients that have bone metastasis only. That's been modified slightly to no bulky disease outside the bone. When they first came out in 2013, you had to have symptomatic bone disease, i.e. bone pain. However, that wasn't what was in the Alsimpica trial, and there was evidence that it works just as well, either preventing bone pain or extending life. So this was modified in 2016, so patients with non-symptomatic bone disease could also be treated. But they had to have failed either abiraterone or enzalutamide, and either failed or unable to have taxanes, such as docetaxel. So if we were to put radium into the what happens to the patient, you can see it comes very close to the end. So if you look at all the treatments, as you start to get metastases, you get enzalutamide or abiraterone. When that fails, you get taxanes. And when you start to get serious events like bone pain, then you get the radium. So we were sort of end of life care, but we were making differences at that point. So just some practical points that come from the guidelines. You need to check the patient is eligible, that they've had a chance to have the other treatments, that there's a recent bone scintigram which shows bone metastasis which haven't responded to either a chemical castration with abiraterone or enzalutamide or other treatments such as taxanes. Before you start the first treatment, you need to make sure there's reasonable bone marrow reserve. We ask for a hemoglobin above 10 grams per deciliter, platelets of more than 150,000 per mil, and white cells more than 1,000 per mil. Now, if they subsequently get of anemia, don't worry, just give them a blood transfusion and carry on the treatment. Now, we want to make sure there's no fracture risk, so if we're worried about that, we will do an X-ray or CT, and if there's a fracture risk, depending what's appropriate, we'll do a single fraction radiotherapy, or we'll get an orthopedic pin put in, and then we'll treat with radium. So again, there's no reason not to treat with radium. You just treat the fracture risk first. And again, make sure there's no bulky soft tissue disease. When we looked at the sub-analysis of Alsimpica, we were getting the best results in patients who had more than 6 metastases. So the guidelines don't say you shouldn't treat with less than 6 metastases, but we get the best results in those above. And I think probably the reason being is that if you have less than 6 bone metastases, you're probably going to live quite a long time anyway. So it may not be the right time to treat with the radium. The right time to intervene is when you have 6 or more metastases. So this is one of our patients, and you can see that in June 2016, they had multiple bone metastases. Now, they weren't riddled with disease, but they had a significant amount of bone metastases. They had quite a lot of bone pain around the pelvis, and clearly they're not in an area you give radiotherapy. The patient had had both docetaxel and enzalutamide, so they were appropriate. We gave them 6 radiums, and 6 months later, there's still a couple of bone metastases, but you can see there's a significant response. And also more satisfying is the patient's bone pain completely went away. So they arrived for treatment 1 in a wheelchair, and by treatment 6, they were booking a cruise so they could go ballroom dancing, which I think demonstrates a very good therapeutic and bone palliation response. Other guidelines have come out. There's been some joint European guidelines from the European Association of Urology and ESTRO, and these came out in 2017, again, basically confirming exactly the same as the NICE guidelines. And the ENM guidelines came out in 2018, and again, pretty much agree with the NICE guidelines. Not because the NICE guidelines are the best guidelines, but because they're based on clinical data from a randomized controlled trial. The Canadian Urological Association last year came out with similar guidelines. And this year, and I was a co-author, the American College of Radiology, American College of Nuclear Medicine, ASTRO, and the SNMI came out with joint guidelines. And they all agreed on treatment, timing, and activity that we should give 6. Now, it has changed from 50 kilobecquerels to 55 kilobecquerels per kilogram. That's not because we're giving a different amount of radium. It's just that the standards change, so we measure it slightly differently. Also, all the guidelines agree, do not get obsessed with PSA. PSA changes very little with radium, but patients can live longer despite the fact their PSA does not change. So if you want to measure something, measure an ALK Phos, but to be honest, what you should do is look at the patient, not just take blood tests. Now, I don't know if you'll be watching this in the future, but if you're watching this now in 2020, we live in a time of COVID. Now, this has actually made a big difference to us because radium has not been shown to cause neutropenia. And after 7 years of use, we've not shown any increase in sepsis or susceptibility to sepsis. This is really important because other treatments like taxanes do this. So NICE issued new guidance in May 2020 for the United Kingdom that radium-223 should now be considered in any castrate-resistant patient with bone-dominant disease before chemotherapy with taxanes. This is really important because what this means is that radium has been identified as an appropriate treatment to give in patients who you're concerned because they may be elderly, have diabetes, or they may be obese or have another comorbidity, which includes their prostate cancer, which means it's not advisable for them to have chemotherapy such as taxanes. If you're unsure about how to give treatment in a COVID secure way, then you can, for free, go onto the British Nuclear Medicine Society website, and you have our most up-to-date advice about how to ensure you can give these treatments in a way that is safe for both you as staff and for the patient in this time of COVID. So in summary, for relief of pain, beta emitters such as P32, strontium-89, and samarium-153 EDTMP work well. These may be the only agents you have available where you are, but we should be using them, particularly in this time of COVID, because they do not cause suppression of the immune system, and they do not cause sepsis. This is really important. Bone marrow toxicity may limit repeat dosing with these agents, but as long as you follow the rules, which is 6 months for strontium and 3 months for samarium, you should be fine. Radium-223, if it's available to you, offers extended life as well as quality of life, but is only approved in prostate cancer. So if you have painful breast cancer metastasis in the bone, you need to go back to strontium or samarium. It is expensive radium, and it's not available everywhere. And obviously, we are looking forward to a future, particularly in prostate cancer, where we have lutetium-177 PSMA coming. And that may just change what happens in the world. We may move towards primarily using lutetium-177 PSMA, because obviously we can treat soft tissue as well as bone metastasis. So I'd like to thank you and finish off with a picture to brighten your life. It's jacaranda season. It's just gone past jacaranda season in Pretoria in South Africa, where I'm a professor, and I thought I'd show you a nice picture of some Pretoria jacaranda trees to cheer you up at this time. Thank you very much.